Hello, I'm Tony DeMaria, the editor of JACC, here with the highlights of the December 18th issue. Trastuzumab is a very effective monoclonal antibody in women who have breast cancer. However, although it's very effective against the breast cancer, it is associated with cardiotoxicity. And in fact, in studies that have been done to this point in time, there's been an absolute increase in heart failure of about 1.6% and an increase in left ventricular dysfunction of more than 7% absolute. However, most of these studies included a relatively younger group of women. And so we have a study in this issue of JACC that studied this monoclonal antibody, Herceptin, in older patients, patients over the age of 67. And to do that, they went and obtained data from the SEER Medicare-related database, and they analyzed three groups of patients: patients who are on Herceptin, patients who are on Herceptin plus an anthracycline agent, and patients who were on neither. And what they found was that there was a significant increase in cardiotoxicity, either heart failure or left ventricular dysfunction, with Herceptin, about a 14% increase. If the patients were on both Herceptin and an anthracycline, then in fact the increase in cardiotoxicity was 23% as opposed to patients who were on neither. So this is important information. The number of patients with breast cancer who are receiving Herceptin in this day and age is progressively increasing, and so we can expect to see more cardiotoxicity, both heart failure and left ventricular dysfunction. These data indicate that this increase in cardiotoxicity is markedly greater in an elderly age group, a group of women over the age of 65. So it's important for us to be vigilant, and number two, to continue looking for prophylactic therapies that maybe can prevent the cardiotoxicity. The December 18th issue of JACC also contains the RIFLE study. Now, this was a study in patients with acute STEMIs, ST segment elevation MIs, who are undergoing primary PCI. And what it consisted of was a comparison between radial artery access and femoral artery access for the percutaneous intervention. Now, this was an Italian study, and they prospectively randomized 1,000 patients, 500 patients in each arm. They then went ahead and performed the procedure, and the endpoint was 30-day MACE, or as they called it, NACE, but major adverse cardiac events. And what they found was that the radial artery access approach proved to be superior. In fact, the number of major adverse events in the patients who had radial artery access was only 13% as compared to 21% in the patients who had femoral artery access. Now, interestingly enough, not only composite MACE was less with radial, but that included both mortality and bleeding at 30 days. Now, there's some important caveats here, in that there was a very low use of bivalirudin, and of course that's associated with less bleeding. And in addition, there was some rescue PCI in patients who'd already received lytics. Nevertheless, these data join an emerging database suggesting that not only for elective PCI, but even for primary PCI in acute coronary syndrome, that radial artery access has an advantage. An interesting study in this issue of JACC deals with the question of whether or not individuals who are physically fit will have a lesser increase a lesser level of biomarkers of myocardial damage, that's troponin, specifically troponin T, and of increased wall stress, that's NT-proBNP. And if they have a lesser level of biomarkers, will that translate into a lesser level of heart failure? And this is all predicated upon the observation that people who have higher levels of troponin and NT-proBNP have a higher odds ratio of developing heart failure over a period of time. So the investigators in this study went to the cardiovascular health study and used that database to extract a group of people who were followed over a period of 2 to 3 years. And during that 2 to 3 year period, they tracked the increase in both troponin and NT-proBNP. And what they found was that people who are physically active, in good shape, highly trained, had a lesser increase in troponin and BNP over the period of follow-up. And in fact, that dramatically decreased their risk of developing heart failure. So interesting data here on a number of accounts. One, some confirmation that in fact biomarkers can predict risk for heart failure, and perhaps even more importantly than that, that exercise conditioning in fact can blunt an increase in biomarkers, and that will be associated with a reduced risk of heart failure. So an interesting group of studies highlighted in the December 18th issue of JACC. I sure hope you enjoy reading it.